Welcome to Vital Signs, the podcast where we bring important healthcare conversations to our communities. This series is dedicated to keeping you informed about the latest healthcare topics, the vital role of community health centers, and the services available to you and your family.
Each episode, we're going to sit down with healthcare experts from Cornerstone Care to discuss the issues that matter most.
Hi, I'm Lesa Trunzo.
And I'm Courtney Downey.
And this is Vital Signs.
Our first ever episode. How excited are you?
I'm so excited. And what two better people to be bringing this?
At three, because we have our expert guest.
We do. Our favorite doctor, our favorite family doctor.
Favorite everything.
Yeah, she's great. She's great. And we're really excited to bring this to you today. Now let's get started. So hormone replacement therapy has been a headlining topic in the media now for the last couple of years. And our expert today is here to answer questions about this topic so vital to women's health. She'll debunk any myths, explain what is available to women who are facing menopause. So Courtney and I are very excited to introduce our very first guest, Dr. Julie Orlosky. And I'm going to read this because I don't want to get this wrong. She's a board-certified family physician and completed her undergraduate training in pre-medicine at the Pennsylvania State University. She has completed her medical school training at the West Virginia School of Osteopathic Medicine in 2009 and went on to complete 3 years of residency training at the Washington Hospital in Washington, PA in family medicine.
She's been practicing a practicing physician here at Cornerstone for the last 13 years at our Burgettstown location. She has a very special interest in helping women as they transition through their perimenopause and menopause journey and has spent countless hours studying this topic. She's given lectures about hormone replacement therapy to resident physicians. She has recently started an HRT virtual clinic here at Cornerstone Care, where she provides care to women across Pennsylvania. And on top of that, she's a mom of 2 children and a wife. She's juggling it all, and we're honored to have her spend some time with us to discuss this very important topic. Dr. Julie Alowski, thank you so much for being here.
Thank you both. I'm very excited to be here. Thank you for having me.
So to get this started, I think it's worth mentioning that we are both patients of yours, and this is a conversation you and I have had more recently. So tell us why this is such an important topic and why you're very passionate about it.
I'm passionate about it. I'm extremely passionate about it for 2 reasons, and one is personal and one is professional. Personally, I'm in my perimenopause era right now. I'm 43 years old, and just talking with colleagues of mine and also friends of mine who are about the same age as me, talking about changes that we noticed that were happening to our bodies, never having trouble sleeping, and then all of a sudden every night waking up at 3 a.m. and sometimes covered in sweat. And the mood changes and the changes to our menstrual cycles and the hair loss and the unexplained weight gain. You're doing everything like you used to, but that stubborn belly fat is coming on and you don't understand it. And so talking with friends of mine that are in the same age group as me, that's the personal reason. The professional is I very quickly realized how uneducated I was on the subject. And that's hard for a physician to say. But we weren't taught about menopause at all in medical school. When I graduated medical school, we were really told about the Women's Health Initiative that came out in 2002, and we can talk about that later, but it was a very, very flawed study. The numbers were skewed. We have now gone back and reevaluated it, and we know that it was probably one of the worst things to ever come out in medicine at that time. But that's what we were told. We were told that hormones cause breast cancer. And then we were pretty much taught when you go 1 year in your life without a period, that is menopause. And that was all they taught us. And I'm not devaluing my medical education. I mean, I've delivered hundreds of babies. I know a lot about different obstetrical pathologies, gynecologic care that I've done throughout my career, but menopause was just not taught to us. So I very quickly realized professionally I needed to learn about this, and I needed to be able to help women. I look back at myself 5-10 years ago in practice, and there were women coming to me and saying, I can't sleep. I've never been depressed in my life, and now I have all of these mood changes, and sex is painful, and my libido's down. And you know what I told them, and I'm embarrassed to say it, but I said, here's an antidepressant. Or here's a sleep medicine. Medicine with side effects, when really, if I would have been educated on it, I could have offered them just a little bit of what their body used to make a lot of, and it can be life-changing. Perimenopause, on average, lasts 7 to 10 years. I mean, and we're all going to go through it. If we live long enough, we will go through this. And so 7 to 10 years of being put on medications and suffering from this. So my personal reason, and then that was my professional. And the last thing on the personal note, too, that I have to point out is my mom was one of the women in 2002 pulled off of her hormones rapidly. And I watched that as a young pre-medical student. I saw, wow. And now looking back, we know that if you're on HRT for 10 years, within 10 years of menopause, you reduce your risk of cardiovascular disease, osteoporosis, and Alzheimer's disease. And she was ripped off of it. And so that's very, very personal and very frustrating. And so that's why I'm passionate about it.
Well, that's really great points.
Yeah.
Really great points.
So I can see why you're so passionate
Yes.
about it. And I want to dive into that just a little bit more. So can we first start talking about perimenopause and what that actually is?
Well, perimenopause is on average 7 to 10 years before our body goes 1 year without a menstrual cycle. So let's back up and talk about premenopause. So premenopause, that's in our teens, our 20s, usually into about our mid-30s. And that's where every single month we have a slow rise in our estrogen. Around day 14 is when our estrogen is at its highest, and that's when we ovulate. And estrogen is our happy hormone. Estrogen, during that period when a woman is ovulating and her estrogen levels are high, she is focused, that brain fog is gone, she has energy, and she feels really great. And then as the cycle goes on after day 14, you slowly decrease the estrogen until it's quite low, and that's when you have your menstrual cycle. So that's premenopause. And so it's a very slow, gradual change in our hormones. Now, in perimenopause, nothing is gradual. It's all erratic. And so we will get these volatile spikes of estrogen. And women on those days, we feel good. We've got that high estrogen. And again, mood is good, estrogen, happy hormone. Now, instead of it gradually decreasing, it just plummets rapidly. And when that happens, now you felt great yesterday, but now today I'm not sleeping, I'm irritable, I have brain fog, I have no energy, my mental clarity is gone. And you think, okay, well, this is what's happening in my life. And then boom, it spikes again and you feel good. Now, also during perimenopause, we are not having erratic spikes in estrogen. Now I'll talk about progesterone, which is our other very important hormone. So progesterone, what does it do? It is our calming hormone. It makes us feel nice and kind of relaxed. It's kind of a drowsy feeling that it gives us. So that is a great thing when we're sleeping at night, when our progesterone is great. But when we lose it throughout perimenopause, again, 7 to 10 years of losing it, now this is when we see the irritability, the mood changes, and the disrupted sleep. The one other hormone that I want to talk about that we do lose during perimenopause is our testosterone. And a lot of women don't realize how important testosterone is for us, just as important as for men. If we actually take our hormone levels in the blood and make them the same value, so it's picogram per deciliter is how they measure it in the blood. And if we make them the same value, testosterone is our highest hormone, not to the amount that a man has, but it's our sex hormone. It's what helps us with energy, maintaining muscle mass, and libido. So it's very important too. And that is another one during perimenopause we are completely losing. Then once you go that full year without the menstrual cycle, You are now postmenopausal, and that's when you have absolutely no estrogen, those are the hot flashes that are waking you up in the middle of the night. That's when you have so much vaginal dryness that I say to women, it's like the Sahara Desert. I mean, it's an awful time, and we have ways to help women through that. And then with that vaginal dryness, you also have pain with intercourse. And now, you're in your late 40s, maybe mid 40s, and your career is great, the kids are a little bit older, but you have pain with intercourse, and that can affect your relationship with your spouse. So that's what happens, and that's why women who are postmenopausal can be on HRT too. And so that is the premenopause, perimenopause, and then the postmenopausal.
So you talk about that 7 to 10 years before menopause begins, and there's no calendar date to say, you know what, Lesa, this is when menopause is going to begin, right? You can't tell me that as a physician. How do you test for that? How do I know that this is the right time for me to say that, maybe this is the path that my health should be on to prepare for that next 10 years?
So testing during perimenopause, and that's specifically testing blood levels with estrogen and progesterone, is pretty unuseful. And the reason why is you're having those erratic fluctuations. So I may check you one day and it may look like, oh, you're fine. Don't worry about it. And then the next day your levels could be very low. And so there's really no clinical value in checking those. It is important, and I do this with every one of my new patients as we're talking about perimenopause and coming up with a treatment plan. I always check thyroid levels. That's very important for women in our age range because thyroid is something that can start to you can start to have some autoimmune issues with it. And then I always check the testosterone. That is something that we can measure in the blood because that's not erratic. It's just a slow decline. And then I check vitamin levels. We're in southwestern Pennsylvania. I think everyone is deficient in vitamin D3. So I do start with just kind of a basic blood panel. But the diagnosis of perimenopause is based upon your symptoms. And I've had women say to me, am I too young to be experiencing this? No. I mean, if we all knew the age in which our moms went through menopause, that would be helpful. But we don't all know that. But no, I mean, it can start. I have some women in their mid-30s that are already starting to have these feelings. And so we make the diagnosis based on you and your symptoms, and then we come up with a treatment plan.
That's great.
Yeah. And just to kind of touch a little bit on, you mentioned symptoms, and you base that mostly off of symptoms. And I might be jumping ahead a little bit here, but you talked about how we have started this virtual HRT clinic here at Cornerstone. And how do patients know what symptoms to talk to you about? So how do you address those in those visits?
I think so I've been prescribing HRT for probably going on 2 to 3 years to my personal patients that I'm their family doctor. And I don't think that at that point in time, they really knew why they were feeling that way. So it was important for me to not be rushed, to hear them, to listen to, it's very simple to write a script and send people on their way. And so I very much needed to know they're not going to come in. Now they might because, the talk about HRT and menopause and perimenopause, as you mentioned at the beginning, Lesa, I mean, it's everywhere right now. It's on Instagram, different social media sites. There's lots of amazing physicians right now publishing books on it. And so I think the information is out there and they can advocate for themselves now that they understand it. But I think when I first started doing it, it was me closing my mouth, listening and caring and taking the time and saying, you're kind of in that age range. Are you also having these symptoms with it? And then usually they would make the diagnosis for me and say, yes, I have been. And I felt funny bringing up that I'm leaking urine or having vaginal dryness, and then that's how the conversation gets started. But it's a lot of the doctor being quiet and listening to the patient because they will give you the diagnosis.
Yeah. Is there a certain set of symptoms that should happen at the same time in order for you to make that diagnosis, or can they be erratic? Or maybe today they're happening, but it doesn't happen again for another 2 weeks?
Absolutely, they can be erratic. So some women come to me and they're in their mid 30s, and even though they still have some estrogen, they're having hot flashes. It's all how your body responds to hormones. It's kind of like if you think of women who are premenopausal and they need to go on birth control because their periods are so horrific. They're having, we call it PMDD, premenstrual dysphoric disorder. So severe PMS with mood changes. So not every woman is like that. And so the same is true with perimenopause symptoms. Some people can present with just, maybe some vaginal dryness or trouble sleeping, and others can come in and it's so erratic. The thing with the menstrual cycle is really interesting because women will, they get that spike in estrogen and everything is good, and they've gone 4 months without a menstrual cycle, and they're thinking, okay, this is going to go away, and then boom, it's back. And for some women, based on that erratic fluctuation, it's back with a vengeance. And I mean, dealing with clotting and lasting a long time. So I guess my answer is it's not one size fits all. Everyone presents a little different, and it's because we all respond to our hormones differently.
Great, thanks.
Yeah. And at the beginning there, is there anything that we do? So let's be honest, people are not really thrilled about talking about this subject, with their doctors. Some people may even have a male doctor that maybe they're not feeling comfortable doing. So is there anything that they can do at home, or any kind of scales or anything like that that can be used in these visits to kind of say, hey, like I'm landing on this scale. So kind of bringing it more to light for them.
Now, yes, there is so much information out there. So there's a lot of great books that have been published on the subject. Dr. Mary Claire Haver has a book published called The New Menopause, and that is kind of like your guide to understanding your body, and there is a scale in there. It's the same scale. It's called the green scale. It's a validated scoring system to kind of see how severe your perimenopause or menopause symptoms are. So I encourage women to get that book, listen to it. It's on audio as well, and that can be a great resource to know, why am I feeling the way that I'm feeling? The green scale is wonderful. I use it. We do it at the initial HRT visit with every patient so that I can see where you are. And then my goal is every time we meet, we do it again. And I want to get it less than 80% of where we started. And I'd really like 100%, but 80 is good. But yeah, and there's so much information out about it now. I mean, even the North American Menopause Society, NAMS, they have a website, has tons of information on there, and not just for patients, for providers too.
I think that's so important for women in general to just kind of learn about it and learn about why they're feeling the way they are. Because as women, we typically say, oh, it's just another thing we're dealing with. Oh, we're going to put it off until finally it becomes so overwhelming. And the fact that there is a treatment now that we know more about, and that women can learn more about, that this it's normal but not normal, if that makes sense.
And that you don't have to suffer through it. For so many years, and I remember my mom telling me this after that study came out in 2002, she was told just suffer through it. I mean, there was nothing they could do. And so now we can help women.
Yeah.
Yep.
So leading up to all of this, talking about perimenopause and all of those good things. So let's talk about hormone replacement therapy. What is it?
So hormone replacement therapy is the way in which I can give women back the hormones that they used to have. And so just in comparison, and to explain the safety of it, a birth control pill has a lot of hormones in it, way more hormones than what we are giving you with HRT. HRT, as I've alluded to earlier, just a little bit of what you used to have a lot of. With the birth control pill, it has to be high levels of hormone because we have to prevent ovulation. With HRT, we are not preventing ovulation. Also, birth control pills are typically taken orally, and when we take estrogen in an oral form, it can increase our risk of blood clots and stroke. And so very important for women who smoke, that's a big risk factor. If they're going to be on the birth control pill, you can still be on HRT if you do smoke, although we want to try to get you off the cigarettes, but you can still be on HRT. And so now let me dive into it. So just comparing it to birth control, very different, not oral, no risk of blood clots or stroke, and much lower amounts of hormone. Also, HRT is all body identical hormones. They mimic exactly what is in our body. These are not the hormones that we used in the 1990s. We were getting that estrogen from the urine of mare horses. It was about 7. Yes, that's how they got it. And I come from a horse family, and so it was quite unethical, and 7 times stronger than our own natural estrogen. And the progesterone that we used back in the 70s, 80s, 90s, it was a synthetic form of it, and again, much higher amounts than what we now use. So we start with an estrogen patch. You can do a gel. There's a spray. I prefer the patch for my patients because it's easy. You change it 1 time a week. You get a steady amount of it. There's also a brand you can change twice weekly. It's a little bit smaller and it sticks a little better. But yes, so it's just a transdermal way of giving your body back some estrogen. Progesterone. Now, if you have a uterus, you have to be on progesterone because progesterone keeps the lining of the uterus very thin. If you didn't have a uterus, if you've had a hysterectomy for whatever reason, you wouldn't have to take progesterone. But I even have some women in my practice that like to be on it even though they don't have a uterus because it helps them sleep at night. So the progesterone is a little pearl-like pill. It's called micronized progesterone. And we take that about an hour before bedtime. You will sleep like a baby. And women are so thankful because they've been going, months without, sometimes years without being able to get a good night's sleep. So that's the estrogen and progesterone. Now, I had mentioned how important testosterone is too. Now, the interesting about testosterone, and I'll try not to get on my soapbox here, women don't deserve it. There is no FDA-approved form of testosterone for us. Men, as soon as men started having erectile dysfunction, or at least talking about it, there was a pill right away, wasn't there?
Sure was.
Yeah. So for women, the way that I give them testosterone is through a compounded cream. It's much lower than the dose that I would give a man. They apply it 1 time per day. And like I said, testosterone is very important. It's going to help women to be prevented from osteoporosis and bone loss turnover, and it will definitely improve their sex drive. So testosterone is so important too. Now, we also have localized estrogen and I really think every woman 40 and older should be on localized vaginal estrogen. I also think, so we can apply this estrogen to our vaginas. It helps with lubrication. It helps to, for a lot of women who are leaking urine, it helps to kind of tighten everything up and plump that area to make it more like it was in our 20s and 30s. And interestingly, the way it moisturizes and plumps, they started using it on the face. And I use it for aesthetic purposes for women all the time.
So you talked a lot about all of these different hormones. And one thing I wanted to kind of touch on a little bit was, growing up when I went through, talking to doctors about birth control, and then social media became a big thing, and just how we got our information was social media driven or Google driven, now TikTok driven. So there was a lot, and you touched on this a little bit at the beginning, but there was a lot of stuff out there about how these hormones will increase your risk of breast cancer or feed breast cancer. Mm-hmm. So can you talk a little bit more about how that's different now opposed to then?
Yes, and I'll talk about both, the causing and then the feeding. So as I had alluded to, the Women's Health Initiative, so very flawed study. The women were outside of the age of when you would typically go through menopause. The average age was 63, and that's not to say that you can't be on HRT when you're 63, but they were far outside the age range. It was a very sick population of women, high amounts of smoking and obesity, and they were using hormones that we don't even use now. But the biggest flaw was the way in which the media skewed the headlines about it. And so when you now you can do a PubMed search on this, it's everywhere. We have gone back and we've reevaluated this study. So what they found is the women in the study that were on estrogen and this synthetic form of progesterone, and actually the women who were just on the estrogen, there was no risk at all. But let me explain the risk in the estrogen and the synthetic progesterone. It went from 4 in 1,000 to 5 in 1,000 was the increase in breast cancer. So statistically, that's a 25% increase, and that was the number, but it's not. If you look at the absolute risk reduction versus the relative risk reduction, and I'll try not to get too much into statistics, it was a 1 in 1,000, but the headlines on every news station was 25% increase in breast cancer. So we have since gone back, we've reevaluated that. The numbers were completely skewed, but the media went crazy on it. And that's when all these women were just told it causes breast cancer. Now, going back to the fact that, so those are not even the hormones we use anymore. And so that's important to remember as well. And there's lots of research now coming out on the safety of this, the prevention of the number one killer of women, which is heart disease. It reduces the risk of not just heart disease, osteoporosis, and Alzheimer's too. So I think that's huge to keep in mind when we're talking about breast cancer. But I say to women all the time, I'm going to teach you about this. You need to weigh I have lots of women who are on this who have family members who have had breast cancer. You need to weigh the benefit and risk for you. The data we have is very safe. The data in the past was obviously, for all of the reasons, quite flawed. But so that's what I say to women. 1 out of every 8 women will hear those terrible, frightening words, you have breast cancer, regardless of anything, life, living, age. As we advance in age, our risk of breast cancer goes up. So that's on the subject of breast cancer and why it was so important to go back and look at this research again and understand it. Feeding of a breast cancer. So yes, if you have an active breast cancer, we know that estrogen and progesterone can feed that. And so that's why being diligent, getting your mammograms every year. Estrogen and you had a ton of estrogen and progesterone in your 20s and 30s and you didn't get breast cancer. It's not causing it, but it can feed it. And especially as our risk goes up as we get older, I just tell women, be very diligent and get that mammogram every single year. I hope that answers everything.
Yeah.
Okay.
Yeah, absolutely. So you brought up feeding the cancer. Can you go into a little bit more of a conversation about what does that mean?
Sure. I guess feeding people may wonder, how does that happen? So when someone gets a breast cancer, we'll typically do, depending on the size of it, the location, some type of biopsy to get the exact cellular nature of it, to know, is this ductal carcinoma in situ, is this infiltrating? There's many different forms of breast cancer. But the one thing that we check for a lot now, and every woman who has to go through this, is for if the cancer has an estrogen receptor and progesterone receptor on it. And many of them do. And when they are, we call it ER or PR positive, when we determine that it is an ER or PR positive, that means that estrogen will cause the cancer to grow and replicate. Or progesterone, the PR is progesterone. And so now for those women, we put them typically for 5 years on a complete estrogen blocking medication. And if you talk to cancer survivors, being on that is probably worse than going through the actual process of diagnosing it, maybe doing radiation or a surgical procedure, because it's for 5 years. And when you block every estrogen receptor in your body, we have estrogen receptors in our entire bodies. So these women have terrible joint pains. We're now finding out there's actually a lot of studies coming out about frozen shoulder being related to lack of estrogen. And then every other symptom I've talked about, they're going to go through it all, and they're going to go through it quickly. And so for those 5 years, it's quite devastating for them. But so that, I hope that answers your question. So they look at the cancer, they determine if it responds to these nutrients, and if it does, we have to stop HRT and we have to block all estrogen and progesterone.
Thank you. Thanks for clarifying that.
Yeah.
To go back a bit, we talked about the estrogen patch, and there's zero risk of blood clots.
Correct.
Can you talk a little bit more about how they don't get clots?
Yes. So when we take estrogen orally, it has to go through our liver. And you're taking something orally, it passes through the hepatic system as part of the filtration of it. And our liver is where our clotting factors are made. So by processing estrogen in the liver, it can affect our clotting factors over time. And that's why, for instance, a woman who has an increased risk of a clotting disorder, there's various ones out there, factor V Leiden, there's one called MHTFR. But for these patients that are taking a birth control pill and it's going through their liver, their risk is much higher. But even in the general population, smoking can increase the risk, like I talked about too. So we as providers, we put patients on birth control pills all the time, and without really thinking about some of the consequences that could come from that. And I'm not putting down the birth control pill. I mean, obviously, we need to be able to offer these things to women to prevent ovulation if they're not in a time frame in their life where they want to get pregnant. But I think it's important to think about the fact that it's an oral form of estrogen. It's high amounts of estrogen and a synthetic progesterone, and it's going through your liver, and it could increase the risk of that. So that's what I mean. When you're taking it orally, it's going through the liver, and that's where your clotting factors are made. By giving women estrogen through a transdermal route, there is zero risk of blood clot or stroke.
Wow. Mm-hmm. That's great.
That's actually amazing.
Yeah.
Yes.
Because that's one of the most worrisome things, I think, when people do get put on birth control. That's the number one thing you see on commercials, on,
Right.
on your package, and you're afraid to take it.
Right. And I think before I knew so much about HRT, I know I was giving women in their 40s, I was starting to treat their symptoms with a birth control pill because that was the only tool I had in my toolbox at that time. And that's why, I didn't mention this completely at the beginning, but I want to point it out. Not many physicians are trained in HRT. Even my colleagues, OBGYN colleagues, they're taught so much about surgeries and delivering babies and all the other pathologies that can come with our reproductive system over time. But many of them are not taught about HRT as well. And so that's why it was so important that I was up countless nights, PubMed searches, thousands of PubMed searches and research on this. And so that's why it's so important in my mind for providers to get educated on it. I've given lectures to the residents about it, but for them to understand, a birth control pill, I was using that in patients in their 40s just to give them a little bit of hormones back, when now we have something that is just as effective and so much safer.
And I wanted to kind of go back a little bit because you touched on this a lot during this, where you talked about it reduces your risk of Alzheimer's, osteoporosis, cardiovascular disease. Mm-hmm. So how does this and why? I guess, why is this all happening now, opposed to back then we didn't know about all of those benefits?
Well, we weren't researching it either. And now we have something that's called the healthy cell hypothesis. And there's lots of different, again, you could PubMed search it, lots of different articles that have come out on each of those disease states. But just simply to put it, we have estrogen receptors in every organ system of our body. And so, for instance, with Alzheimer's disease, starting a woman within 10 years of menopause and keeping them on it for at least 10 years, you have estrogen receptors in the brain that remember how I told you at the beginning how when our estrogen levels are high, we don't have brain fog. We're sharp. Those are the days our mental clarity is there. And so, and there's actually Dr. Laura Mosconi, she has a book out now called The Menopause Brain. And that has I won't dive into all the research studies, but so starting with Alzheimer's, the estrogen receptors in the brain. Now let's go to our bones. Bones, estrogen receptors. That's why when these women are put on these estrogen blocking agents, when they have breast cancer, they need to be getting their bone densities checked frequently because it could lead to rapid bone loss and turnover. So we have estrogen receptors on our bone. In our heart, studies have shown, and there's one particular study that came out showing that treating high cholesterol with HRT offers more of a benefit than statins.
Wow.
Other lipid-lowering agents. And again, those are pills. Those are medicine. Once you go on it, you're usually on it. Those have side effects too. You know, they talk a lot about statins right now and the risk of Alzheimer's disease. So estrogen receptors, every organ system of our body, improving cholesterol, decreasing risk of plaque formation, which in turn leads to cardiovascular disease, stopping bone loss, stopping the bone turnover that occurs. We're constantly, and this is why I talk to women so much about weightlifting and weight-bearing exercises. I tell every woman in my virtual clinic, get one of those weighted vests. And I know it doesn't look great, but who cares? We're in our perimenopause era. Put that weighted vest on and go walking because we are losing bone mass rapidly. The most recent statistic I saw said that once a woman goes through menopause, her risk of having a fracture before she dies is 50%.
Oh,
Wow.
50%. And so by protecting the bones, doing the weight-bearing exercises, testosterone, what does testosterone do? It helps us build muscle mass. The biggest muscle in our body is our quadriceps. So you've heard of people breaking their hip. The quadricep attaches to our hip bone. So every time we're building that muscle, it pulls on the hip bone, has it via a tendon, making it stronger and constantly getting those bones, for rebuilding the bone. So I hope that answered your question. So yes, estrogen receptors everywhere, and there will be more research coming out on it too. I'm sure of it.
yeah.
And sorry.
Go for it.
You said something in there that I realized that we haven't talked about yet is you've talked about all of these side effects that you get with oral medications or birth control or cholesterol medicine even. Are there side effects to things like the estrogen patch or the progesterone pill?
So remember, it's not a medicine. It's just giving you a little bit of what you had a lot of. I know I say
love
that. But well, I say that to women all the time because it's, yes, your body is losing this. And I've had women say, are we going against science by putting a little more of this in our body? Well, are we going against science by taking a statin or an antidepressant or a sleep aid? And so, now, what was your question? Though
It was just about side effects.
Oh, but the side effects, yes. Okay, so the top 2 side effects that I see with women when I start them on HRT is we awaken their uterus. And so by awakening, these women may be postmenopausal and now they start bleeding again, and that can be very worrisome to them. It should resolve on its own, and if it doesn't, we decrease the dose of the estrogen. It's not, when I'm choosing what dosage to put women on, again, it's not one size fits all. So some women will do great. Usually if they're more in their perimenopause era, we're going to go a little higher with the amount of estrogen. But yes, so estrogen can awaken the uterus and you can get vaginal bleeding when you haven't had any. Again, usually resolves, or I started you too high and we need to decrease it. The other side effect is breast tenderness. So very common, if you remember, when you're first pregnant, those hormones are so high, and we all experience breast tenderness, and that's kind of what happens when we start giving you back some of these hormones. That should resolve on its own. If it doesn't, we decrease the estrogen. For progesterone, not all women can tolerate it, and in the oral form that we take at bedtime. So some women can have some bloating from it or just too much drowsiness. So in that case, I can either decrease the dose, or sometimes I increase the dose because it also helps to keep the lining of your uterus thin so that vaginal bleeding goes away. But for my women who can't tolerate the oral form of it, IUDs are a great option to deliver progesterone to those women. And I even have some women who have the progesterone IUD, but they still want to take the little progesterone pill at bedtime to help with sleep too. So, but those are the main side effects that can come from this. Be diligent, get your mammograms. As I said before, HRT does not cause breast cancer, but 1 out of every 8 of us will get it from living. The other risk factors are, we now know alcohol is a big risk factor for breast cancer. Sedentary lifestyle, having a diet high in processed foods. So I say to women who are very fearful, if we're living that lifestyle, we're increasing our risk of breast cancer too.
Yeah. So we talked about when was the perfect timing, so to speak. When should someone stop HRT? Like, what's that perfect time where we're supposed to say, okay, we've done all this. Now when is it supposed to end?
Never. It never has to end. Now, if you did develop a breast cancer, yes, we would absolutely stop it, and then you would have to go on the medication to block that. Now, can a breast cancer survivor take HRT in the future? Yes, they can, and there's lots of studies. In Dr. Mary Claire Haver's book, she has a whole section on being a breast cancer survivor and taking HRT. If your quality of life is gone, you're weighing the risk versus benefit. But to answer your question, you never have to stop it. I have several ladies in their 70s. Probably as time goes on, I'll have some women in their 80s on it. Personally, my friends and I joke and we say, when they're nailing our coffin shut, we're going to have an estrogen patch on because it helps so much with going through this transition in your life, and we know the safety of it. So there is absolutely no reason if you feel great on it, it's protecting your bones, it's protecting you from all those diseases, we can certainly stay on it.
So I think my next question to you is, and I think a lot of women would want to know if there's hesitancy on taking medication, are there any homeopathic routes that they can take at home or through exercise that would have the same benefits?
Yes, absolutely. So I already talked about the importance of weight-bearing exercise. That I cannot stress enough, as we are losing muscle mass every single day. And so muscle is the metabolic Spanx of the body. And so, and muscle protects our bones too. Now, how do we keep our muscles strong when we're not just talking about weight-bearing exercises? Creatine is a supplement that I actually recommend for all women over the age of 40. It is the most widely studied supplement out there. And it's so funny because women will say to me, creatine, isn't that for bodybuilders? I don't want, if I had a dime for every single time a woman said to me, I don't want to get bulky. You're not going to get bulky. Our hormones don't even allow for that. But creatine, the research now at helping, so when we use our muscles, we produce something called ATP, and that's like the energy in our cell to help us do that extra rep or do the exercise we're trying to perform. Creatine helps feed the ATP, and so you might be able to get that extra rep in. You might be able to go that extra mile. You might be able to increase the weight in your weighted vest. We also now have studies coming out on the role of creatine with cognition and helping our brain cells to function properly. They're looking at patients who have had concussions and how healing from that creatine could play a big role in that. So creatine, definitely important. Fiber is so creatine's my number one. Well, weightlifting's my number one. Creatine and fiber. Fiber helps fill us up. It keeps us satiated longer. And not just in the form of, you can use a substance like Benefiber, and it is a prebiotic too, which means it helps our gut bacteria to work properly. So certainly you can do a supplement like that if it's a day that you didn't get a lot of green leafy vegetables in, but trying to get it through natural sources and berries and nuts and beans and definitely through the green leafy vegetables too. So fiber, vitamin D. Vitamin D3, I think every woman should be on it. You can get too much vitamin D3, and so it's important for you to be working with your provider. I keep an eye on those levels, but it's important for our bones. Most women, I would say at least 90% of women that I check are deficient in vitamin D3. And fish oil. Fish oil, so anti-inflammatory in our bodies. If we're eating wild-caught salmon every day, maybe you could skip it on that day, but I don't know if we're always eating that way. So fish oil plays a huge anti-inflammatory role in our body. Those are, and one more, magnesium glycinate. Magnesium, most of us are deficient in magnesium. And so when I hear the women, so the first supplements I was talking about, that's more for bone health, vitamin D for our bones, fiber to help us with weight loss because you're full longer. But when we get to the sleep, if a woman doesn't tolerate the progesterone or doesn't want to take it, maybe she's had the hysterectomy and she doesn't need it, magnesium glycinate. So there's various forms of magnesium. There's magnesium citrate and oxide, and those are more laxative type effects. And there's a magnesium that crosses your blood-brain barrier. That's called magnesium threonate. Magnesium glycinate. So what I'm saying is magnesium is not magnesium is not magnesium. You have to look for magnesium glycinate, and you take it before bedtime, and it can just help relax the body and kind of help your muscles to calm down and relax too. So those would be my supplements, but absolutely from the a homeopathic or even a holistic standpoint, mind, body, spirit. You know, I'm a doctor of osteopathic medicine, and the foundation of osteopathy is the mind, body, spirit connection. So, you know, waking up, getting that sunlight, getting some natural sunlight for your vitamin D, putting on that weighted vest, getting your steps in every day, making sure that you are eating a good diet and taking those supplements that I talked about, and weightlifting.
Weightlifting.
Yes.
Personal
Lift
testament
heavy.
to the magnesium glycinate. She put me on it recently, and my sleep has never been better.
Yes.
It's good to know.
Yes.
Good to know.
It's amazing.
So is there anything else that you would want someone to know before starting their HRT journey?
Well, I think the most important thing, you know, now that I have this virtual clinic, is come and talk to me. You know, you might have questions that we didn't even talk about today, fears that you may have, more questions about the WHI study, more questions about taking it, and maybe the patch isn't right for you. And I will point out, some women do get some skin irritation with the patch, but I have lots of tricks to help with that too. But yes, so I have this virtual clinic now on Fridays, and so you don't even have to live close to my practice. And the wonderful thing about that is we can talk. We can answer any questions. You don't have to come to me and think, oh, she's going to put me on HRT. No. I am a doctor. I am not a dictator. So I want to answer any questions you have. Maybe like the question you asked earlier, Lesa, maybe you don't know if you're in perimenopause. Maybe you think you're too young. Yes, so that's what I'm getting at. Make the appointment. We can talk about it. We can talk about it in the comfort of your own home, and then we can decide if we want to start treatment. Maybe we just want to start with some blood work. Maybe something else is going on, like the thyroid that I mentioned. I didn't mention this earlier, but another thing that a lot of these women have is iron deficiency, because during this perimenopause phase, 7 to 10 years, you can have heavy periods. And so that's losing blood and losing iron. And so sometimes just replacing some iron in those women can make them feel so much better.
Yeah, I think all of the things that you talked about were so important because I think that women don't know that some of these symptoms are, in fact, perimenopause or, dry skin, things like that. Like, I would never think that that's what that was.
Right. Oh, dry skin, itchy ears. The vaginal cream that we
Really?
talked about, the vaginal cream that you can use on your face, you can just put a little bit in your ears and it makes such
Itchy
a
ears.
difference.
I would have
And
never
no,
thought about
no.
that.
No.
Yes, it's true because everything dries out. That's why when we put estrogen in our vagina, it gets all nice and lubricated. We start using it on our face. Now our crow's lines are a little bit better because everything is plumped up. And so it can make a big, big, big difference for women.
So you're talking about these vaginal creams and the hormones that are in them. Can you transfer those to someone? I'm absorbing them into my skin. I'm touching pets. I'm hugging my husband. Would those things wear off?
So let's start with the localized estrogen, again, that you can use in your vagina or on your face. I've had many women ask me if I put the estrogen in my vagina and then I have intercourse with my husband, will he then get estrogen effects? And my answer is typically he would have to have the most permeable penis ever for him to absorb any amount of estrogen that would be demasculinizing for him. So you can definitely use the estrogen cream and still have intercourse with your partner. And you can also, men could put, this localized estrogen is so safe. It's not getting absorbed into our bloodstream. So if men wanted to use it around their crow's feet or the 11s, the forehead lines, they could certainly do that as well. Now with testosterone cream, you do need to be very cautious. I usually have my women apply it. It's a compounded cream, and I usually have them put it on their forearms and then rub it in like this so that it's never touching your fingertips. It does absorb quickly, but if you had a newborn, if even a pet or something that you were holding right after that, you would want to be cautious with that. I do have a lot of women who prefer to put it on their inner thighs so that it's not touching as many areas, and that's fine too. And you can rotate the sites. But yes, you do want to be cautious with the testosterone. But again, I want to point out that the testosterone cream I'm using is just a small dose for women. This has nothing like men who have FDA approved testosterone, like androgel and intramuscular testosterone. Nothing like what they have. This is a compounded form. I think eventually we will have our own FDA approved form of it, I hope.
Hopefully sooner than later.
Yes.
Dr. Alowski, this has been amazing. I know we've had these conversations. I'm glad that we've been able to use this platform to educate more people because, scrolling on TikTok at night, there's all kind of doctors and would-be doctors, and I think sometimes there's a lot of mixed conversation out there and a lot of myths, and I'm so glad that you were able to clear it up. Is there anything else you want us to know? Anything else you want to say to women?
Well, I think this kind of goes back to the reason I'm so passionate about it. So I want women to know we're all going to go through this. If we live long enough, we're all going to go through it. So I want them to know that help is out there. I know that sometimes, a lot of the women that I talk to during my virtual clinic, they haven't been heard. They've brought it up to their family doctors, and I don't blame the family doctors. We weren't taught about it. You have to take the time and go back and do the research. And so I guess I want them to know that help is coming. I think that, the more we talk about this, even today's podcast and all the other resources that are out there now, I do think the tides will change, and I do think they will be heard. But for the women who are listening and they feel like all of their symptoms have been dismissed, I want them to know that I am here for them. There are some other practices in the area too that are offering this to women now. So be your own advocate and don't take no for an answer, and find the person who will do what I said earlier, the doctor that goes in, closes their mouth, and listens to you. No judgment. There's no dumb questions. We can go through it all together. So I want them to know they can come to me. So I do this virtual clinic on Fridays. It's just 2 Fridays per month now, but I hope to expand that over time if I can help more women. And so that's what I want them to know, that their symptoms are real, and not to be dismissed by a provider and then just say, nobody's going to help me.
Yeah.
Keep fighting.
Well, you're amazing as always.
Well, thank you.
And I thank you so much. I think we both thank you for coming here and talking about this. And this has been so eye-opening. And I really hope that it reaches women all over Southwestern Pennsylvania and beyond and in our communities, because that's where it matters. So
Yes.
Thank you.
Well, thank you both. You were wonderful. I really enjoyed myself. So let me know if you want me to come back and talk on something else.
maybe we can talk. Maybe we can talk about male hormones and what that
Yes,
means too
yes.
in a future episode.
I would love that.
Well,
Yes.
thank you.
Okay, thank you.